David. So up next we have Michael and Derek, who are going to be co-presenting. Michael Taylor is an epidemiologist by training who is now a third-year MD, MBA student at the University of Alberta. As a senior analyst with Alberta Health Services since 2014, he has worked on the Alberta Rectal Cancer Initiative in a variety of leadership and coordination roles. Michael is an aspiring medical innovator with a passion for health services research, quality improvement, and a long history of advocacy within the Canadian Diabetes Association. He's a relatively new addition to the Edmonton Men's Health Collective, having been a member of the community-based research team since January of 2017. And Derek Fehr is a third-year MD student also at the University of Alberta. As president of the Faculty of Medicine and Dentistry's Student-Led Sexuality and Gender Advocacy Committee, he organizes the annual Inclusive Health Conference and has successfully implemented several changes to the medical school curriculum on LGBTQ competencies. He's a regular lecturer on LGBTQ health for the University of Alberta's Faculty of Nursing, and he was a founding member of the Edmonton's Men's Health Collective and currently serves as a board member and team lead for community-based research. So I will welcome you two up.
Good. Do you have our slides? They should be loading now. Awesome, thank you. So we'll be co-presenting. I'm going to open with the first half, and then Michael's going to follow. So our research was around HIV and STI testing barriers and preferences in Alberta, gay, bisexual, trans, and queer men. It was a community-based research survey that we conducted earlier this year.
Your slides are not showing up.
Oh, our slides are not showing up. Oh, oh no.
I think it's because it's a PDF.
Oh no.
Yeah, I'll just find it.
Okay.
They're using PDF, if that makes a difference.
That makes a difference.
Well, that is a failure on my part. It's the whole thing with Google Slides and
Google Slides.
oh,
We got a PDF from it.
okay. Oh,
So
that
that's
was an easy fix.
so you won't be able to see your presentation though on this computer.
Okay.
That's fine.
It's okay. And I think it's control. No, there we go.
Okay, great.
Okay.
And
Just advance the same.
okay, fantastic.
I can work with you.
Great. Great. So a little bit background about who we are as an organization. This research was done through the Edmonton Men's Health Collective. We are a grassroots queer health movement founded in Edmonton in 2015 with the goal of equitable opportunity for health for gay, bisexual, trans, and queer men, as well as masculine identified individuals. And a central part of that mission is around community-based research, because there really is a huge lack of Edmonton and Alberta-specific data to inform a lot of the health interventions in the province. And so our community-based research team was focused on doing that, and that's how this research came about. And a piece of, or how this research specifically happened, this project was a partnership with Alberta Health Services. So Alberta Health Services realized that there was a lack of input from the community when it came to gay, bisexual, and MSM health research, and so they reached out to us to have some community input on their recent sexually transmitted and bloodborne infections strategy. And so a number of our members were on subcommittees and the steering committee. And the specific areas that they looked at in this committee was around prevention, screening, treatment, support, and stigma. And that what formed the structure for our project. Yeah, and as I mentioned before, there's a big lack of Edmonton and Alberta-specific data, and Alberta Health Services was really interested in getting community input to alleviate that. So our survey was developed in conjunction with those areas, priority areas from Alberta Health Services. And I listed on the right side the different subjects that we covered in our survey. It was quite extensive. Today, we're just going to be focusing on the partner notification and HIV and STI testing portions of our survey. We put together questions, hopefully looking at, as much as possible, we looked at validated questions from existing surveys in the literature. We also did validity testing by getting experts in epidemiology, infectious diseases, and community-based research to validate a lot of the content that we developed. As far as our respondents, we had 368 from across Alberta, which was considerably more than we expected. The majority were gay men with 81%, but we did have a number of different identities, and we have them listed there. We allowed people to self-identify. It wasn't specific checkboxes. We had people select them or write in responses themselves to be inclusive as possible. It was predominantly white men. Cisgender males were 89%, but we did have, if we combined people that identified as transgender as well as gender non-binary, we had about 10%. And so we haven't done that yet, but what we would like to do, what we're planning on doing in the future is isolating those responses, because we should be able to get some significant, hopefully get some significant data from those respondents specifically. And it was mostly focused in the Edmonton area. That's where most of our promotion was done. It was all of our promotion was through social media, but we did get a number of responses from Calgary and some smaller rural centers as well. As far as age, predominantly young adults between the ages of 18 and 39. 49, almost 50% were single. 22% in closed monogamous relationships, and 15.8% in open monogamous relationships. And we had only 23 respondents indicate that they had positive HIV status, and so that is another population subset that we haven't looked at yet, but that we would like to or will plan to specifically look at those responses and see if there's any difference from the general responses. So as far as the results from our data go, first we'll start with the partner notification section. So we asked respondents a hypothetical question: if they were exposed to an STI other than HIV and a healthcare provider was trying to inform them, how appropriate would they find each of the following methods of contact? And so the vast majority found that contact via phone or in person were the most appropriate, with some indicating email and text was sort of mixed. We asked the same question separately, but a similar question separately, but about HIV. So we split those two to see if there was any differences around STIs and HIV. And the responses were pretty similar, but there were more responses that indicated that phone and in-person are more acceptable around HIV. Considerably more for HIV. A couple of the other options that were not acceptable, this is the same question, but looking at dating and hookup sites, dating and hookup apps, as well as social media like Facebook. So this is the same question, but these were responses that respondents said would not be acceptable to have a healthcare provider reach out to them to notify them of a potential STI. So they don't want to be contacted on any hookup apps or on social media about potential exposures. And it was the same thing for HIV. Very unacceptable from the respondents in our survey. We also asked some questions about where participants were meeting their partners, and unsurprisingly, as our colleagues presented earlier, a lot of gay, bisexual, MSM are meeting partners over mobile apps, hookup sites, and online in general. And then we wanted to know how much contact information they had about their partners. And the majority could provide their phone numbers for their partners, but there was a significant number. So if we look at only about 30% of respondents, almost, or 28%, could not provide a phone number, and even less could provide an email. but 64% could identify them on an online app, as well as 50% could identify them on a hookup app. So this told us that there was a significant opportunity to use some of these apps and new ways that guys are meeting their partners to do some partner notification. Because we also asked, so this question was only asked to people that indicated that they had been asked by a provider or contacted by a provider about a potential exposure. And we asked which of the following acted as barriers to providing contact information for their partners. And 41% said that not knowing the names and or contact information of their sexual contacts was a barrier. A significant number, 34%, said that embarrassment or shame, and 30% said concerns about privacy were also barriers to notifying their partners. So to put all this together, we wanted to find out how we could apply this and how we could make an impact on improving the partner notification process. And Alberta Health Services had already identified this as an issue of MSM only being able to contact their partners via apps and via social media or the internet. And they were very interested in having STI nurses use Grindr, use Scruff to contact potential partners themselves. But as our research showed, that most of our respondents would find that very inappropriate. And so what we did as a way to meet in the middle with Alberta Health Services was we provided training and education to partner notification nurses about how to counsel counsel patients on using these apps themselves to notify their own partners. Because as our results showed, most respondents wanted the opportunity to contact their own partners themselves. And so if our nurses and any healthcare providers counseling on notification know how these apps work and know what functionality there is for searching for usernames, for searching by location, then they're better able to counsel patients on how to inform the partners themselves using some of these social media apps and hookup websites. And so that's one way that we've applied this research with Alberta Health Services already. I'll turn it over to Michael to go over the rest of the results.
Thank you, Derek. Working on an iPad and up here trying to accommodate that. So a little bit of the piece about STI and HIV testing specific to identifying not only barriers to individuals responding and what they perceive as getting in the way of them actually accessing testing, but as well what is significant for them and how they consider their testing and how they consider their own sexual health. So in this question specifically, we were just trying to get a bit of a pulse check, and I apologize if you can't see that text, but we're looking at just how often individuals are getting tested. It's a simple question that we need to ask our respondents in order to get an assessment of how they perceive their own barriers. And a large majority are getting tested at least every 6 months. Now I say a large majority, this is the portion here in the bottom in the gray, and the orange are getting tested at least once every 3 months in the orange and every 6 months in the gray. So a large proportion of our respondents. And as well, this is also for HIV. So the previous slide was for STI testing. This is for HIV. We did tend to split up that data because we thought that we would try to elucidate any kind of differences between them. But then we asked the question specific to barriers. What do you find to be a unique barrier or a specific barrier to you accessing testing? And the top 3 that I'll speak to there are distance, no option to book an appointment, and hours. And a lot of that comes down to just pure common sense. If you're walking into a clinic, a very busy clinic with quite a long line, it's going to be a bit of a barrier for someone who may or may not be hesitant to actually go to get testing to begin with. Distance is a very unique thing to Alberta right now, given that, yes, a lot of our respondents were from Edmonton, but we also have a very large rural population in Alberta and a very unique geographic city center dynamic that may be a barrier to our rural respondents who are unable to actually get to a testing center with ease. And as we mentioned, inconvenient testing hours came out as a very significant factor, let alone barrier, to individuals as far as accessing their testing. So in this slide here, we just asked, what are significant factors for you related to your testing? And hours came out with the highest proportion of people who thought that this was very important to them actually getting themselves tested. So we asked the question, anticipating this response, what would be better suited for you? And much like a bank, weekends and weekday evenings were highly selected. And if you look at the pale blue bars and the orange bars, those are likely or very likely, contributed to a large majority of what people would prefer, not necessarily prefer, but would find at least of benefit to them to actually getting themselves tested. Not necessarily between the weekday or weekday morning hours when people are generally going to work. So what do we gather from this is that our hours, our location, and lack of appointments can actually be a significant barrier to accessing HIV or STI testing. So what we've kind of garnered here is that I use the example of a bank, but let's talk about sexual health in that aspect, and that we need hours that are accessible to everybody. And that may be more often on weekday evenings or on the weekends. So something along those lines, it seems like a very simple consideration, but there may not be the funding in place to actually do so. A lot of the STI clinics that individuals may go to are already strapped for funding and already strapped for the manpower to facilitate the actual testing. To get an STI nurse in there and to get a healthcare provider that can administer the test costs extra healthcare dollars. So we're very cognizant of the fact that there's limitations systematically as well as in practicality. So moving on, we're talking a little bit about the testing methods as well. We wanted to know every bit of preferences that we could possibly get. And so we asked about the receptibility of online HIV testing, that being you download a requisition yourself, you get that filled out, and you can take it to a lab. In Edmonton, DynaLife is pretty much our main laboratory systems. And you can just take it to there, get your results sent directly to you, and you don't necessarily have to go through a healthcare provider for that. We asked about at-home HIV testing as well, that being an option, if individuals would be receptive to that. As well, rapid HIV testing, standard HIV testing, and STI testing as well. These are things that are already available, but in varying degrees throughout the province and throughout the city as well. So what we can gather here is at least there is a demand for new methods as well as a diverse method approach as far as testing is concerned. Whether that is through online requisition forms or at-home testing, obviously there's going to be caveats of that I'm sure we'll speak to at the summit today or tomorrow. There are practical needs for diversity in the amount of testing, in the kinds of testing that are available for these men. But the question we propose to you, and hopefully we'll get maybe an attempted answer later, is how do we approach AHS and our governing body to actually bring this out in the community, to actually facilitate this in our Alberta Health Services facilities. So next, we asked about locations. It's very common to get testing done at an STI clinic. It's hassle-free in Toronto is a very good example of a very frequently visited STI clinic. Edmonton also has similar clinics as well, and that's frequently where individuals are going to get their testing done. But as well, there was a need, or at least a preference noted, for an LGBTQ plus specialized clinic, which Edmonton currently doesn't have. Also, going to your doctor's office. We talked before, at least in the morning, about how a lot of patients would prefer to go to their family doctor to get testing done, whether that's strictly because of the environment of going to an STI clinic, the long lines, the hours, whatever the case may be. Booking an appointment with your family physician, you already have an intimate relationship with that provider. Some of the ones, we're presenting these as the least likely and the most likely, and again, bathhouse isn't exactly the ideal place to be getting tested according to the participants, nor is a bar or club, and I'd say I would agree with that personally. But as far as individuals actually who they would receive the test from or who they would prefer to get the testing from, there really wasn't a specific preference. If the individual was a healthcare provider, whether it's an STI nurse or an otherwise just any other kind of nurse, or a healthcare provider as a physician, it really didn't seem like there was a huge amount of discrepancy. But what was unique is that yourself and online were frequently submitted. So we wanted to kind of bring out the issue of the healthcare provider. And what we were pleasantly surprised with is that a large majority of the respondents actually do have a family physician. And as far as what we can garner from that, we asked a little bit more specific questions about the interaction between these men and their interaction with their healthcare providers. So their main healthcare provider being a family physician, it seems like a great proportion of them have also come out to their family doctor. They're comfortable talking about their sexual health with their family doctor. But the discrepancy we note is that 33% had actually had their family doctor initiate a conversation about sexual health with them. So there we see a bit of the discrepancy that can color a bit of the recommendations we have on the next slide. So we see that the majority of the respondents do have a family doctor and they'd like to get tested from them. But why only 33% getting the conversation broached? Where's the misconnect there? So we decided, rather than focusing on the potential for discriminatory practice in the medical field, we've tried to focus on maybe there's financial incentivization that isn't in place. Family doctors bring home, they work on a fee-for-service model, and currently in Alberta, they cannot bill for swabs for a rectal or throat. So this may be a barrier for them to actually facilitate more thorough testing with their patients. Just putting that out there. But as we know, there is an evidence gap between the data that's collected in Alberta and what we have to say based on self-report for physicians and patients as well. As mentioned before, the need for an LGBTQ plus specialized clinic is evident based on our responses. However, we're not necessarily saying this is feasible with funding limitations. However, we're noting a need for a specialized clinic in a population that doesn't have one. So a little bit of summary as far as what we're hoping to put forward here. Some of our strategic recommendations include developing primary screening guidelines for our family physicians so that they feel better and more capable to approach the conversation with their GBTQ patients, as well as feel comfortable and incentivized, if need, to actually perform the thorough testing that they need to be done, and to offer that testing to the individuals, regardless of whether or not they think that they're at a specifically high risk than others. As well, we think that the implementation of possible online screening and self-collection options is something that AHS should consider, and we would be happy to take recommendations on how we should approach this otherwise from other than a detailed report that we'll be sending through AHS in our strategy. So what we hope to do, at least with these recommendations, is to formalize them in a report to AHS, and as well to draft our implementation recommendations that are both within and outside of the budget constraints that AHS is currently dealing with. But what we know is that this project demonstrates a very low-cost, easy way to take a pulse of a community that is otherwise untouched by Alberta Health Services right now. We've given them the data, and we've provided the data as a start, but there's a long way to go. This is just the beginning for the research that we'll be doing in the community. So the EMHC has now also been invited to collaborate as far as modules to help train, as Derek mentioned, our healthcare providers to do better. So we hope to keep fostering that relationship in the future. Thank you.